It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back and thanks for listening. So I do have some upcoming courses for ultrasound-guided regional anesthesia and IV vascular access coming up in New York and Detroit. We just did the Florida course. It went really well. And I just check out nrappain.org for board prep for the pain boards, as well as see the CME live workshop schedule. In addition, I've been considering private coaching for ultrasound as well as for board prep. So if you're interested, just shoot me an email. This podcast today is really a look at the platelet-rich plasma injection into the caudal epidural space. And now I do consulting work and network with doctors in other countries in the States. And I'm well aware, and you're probably aware if you listen to the podcast with Dr. Dos Santos from Barcelona, that a lot of pain physicians outside the U.S. will use ultrasound for their procedures, and caudal is super easy to do under ultrasound in most patients. So I've seen doctors doing PRP using ultrasound or X-ray into the caudal space. I've definitely done it myself, and I've seen amazing results. And I decided to just do a little journal club about this topic. Here's an article where they did a randomized, double-blind, controlled pilot study comparing leukocyte-rich PRP and corticosteroid in the caudal epidural space for complex chronic degenerative spinal pain. They took 50 eligible patients, randomly assigned to each group, so 1-to-1 was the ratio, and it was either triamcinolone, 60 milligrams, or leukocyte-rich PRP from a 60 milliliter autologous blood sample. The low back pain and quality of life and complications or adverse effects were evaluated at 1, 3, and 6 months after treatment. Pain levels and quality of life were measured using the VAS and short form 36-item health survey, respectively. No significant differences between the groups. Compared with the pre-treatment groups, there were significant reductions in VAS score in both groups. A significantly lower VAS score at 1 month was detected in patients who received the steroid. However, the scores were lower in the leukocyte-rich PRP group at 3 and 6 months follow-up. The SF-36 responses at 6 months showed significant improvement in all domains in the leukocyte-rich PRP group. There were no complications or adverse effects following the 6 months follow-up in either group. Both autologous leukocyte-rich PRP and corticosteroid for caudal epidurals under fluoroscopic guidance were equally safe and therapeutically effective in patients with chronic lumbar spine pain. However, the leukocyte-rich PRP is superior to corticosteroid for longer pain-relieving effect and improvement of quality of life. And just as an aside, I received my PRP injection. It was a transforaminal into my back about 10 weeks ago now, 9 or 10 weeks ago, and I'm starting to feel much better. Although, in all honesty, today it's raining in New York, and I do feel a little something, like a 0.5 out of 10 pain, maybe in my leg only. But overall, I've been much better over the last 2 weeks. I think it started to kick in slowly over weeks 4 to 8, and more noticeable weeks 8 to the current time, week 9 or 10. So what shocks me is young fellows who I talk to coming out of academic programs are saying, we didn't do PRP. We were told there's no evidence, or it's just a scam to make money. Now, I admit the evidence does need to be stronger. We do need more studies. We do need larger studies. But this is not cardiology where we're talking about 10,000 patients. It's pain management. Unfortunately, we don't have that luxury. And if you have a treatment that is safer, just because it's a cash-paying procedure does not mean it's evil or just to make money for the doctor. it is actually, so far as we understand it, safer and lasts longer than steroids. So why are we not offering this therapy as a first-line therapy? If this is the therapy what the doctor is doing for himself and recommending for his family members, why are we not at least having that conversation with the patient, even if you think they can't afford it? I have patients in my practice who you never know if they can afford it. They can afford a trip to Florida for the weekend, so they probably can afford a PRP shot in their back, especially if it's going to truly help them more than steroid, give them less side effects, and last longer, and get them back to work. So I had visited a clinic, and one of the patients at that clinic agreed to do a testimonial about the PRP injection. This patient was about to go for surgery. She was a nurse, and she was told that she needed surgery. She had, one of the docs gave her PRP, and about, I think she improved early, like 1 month, but at the 2-month mark, people in the hospital were looking at her and asking her, "Oh, I see you did the surgery." And she's like, "No, I did not do the surgery. I had the PRP." So PRP for spine is here to stay. And if you're not doing it, continue to do your own research. Look at the data. I tell my patients, don't go on Google. Go on Google Scholar or any of the journal websites. Look at the actual data that we're looking at and see for yourself. And even if there's a small improvement, it seems to be a large improvement over steroid, but even if it's a small improvement compared to steroid, at least you have less side effects, right? You're not giving anyone osteoporosis or diabetes with excessive PRP injections. Now, unfortunately, it's not covered, which is another story. However, just because it's not covered doesn't mean that you shouldn't offer. In fact, with the way things are going, not much is going to be covered, right? They want to cut all these nerve blocks that we're doing that have been proven to help people with their pain. It's completely ridiculous and maybe criminal, actually. I mean, if they're going to cut services and they don't want us to give opiates, which that I understand, but then they don't want us to use interventions to target the pain therapy and treat it, well, what's the point? The point is they want to save money and they want the patients to be responsible for their bills. I pride my practice on minimizing surgeries and unnecessary meds for my patients. My latest I guess saying to patients is I treat my own pain with turmeric, PRP, and Pilates. I kind of like Pilates better than PT because I find it to be more of like a workout as opposed to just a therapy session. But a lot of the Pilates work, if you don't know much about it, check it out. It's super good for the core, and it's relatively safe with respect to weight bearing on the joints and spine. That being said, you can hurt yourself during Pilates like anything else. But check it out. I mean, this is what I'm doing for myself. And then when it comes to medication, I mean, one of my go-to drugs is low-dose naltrexone. I'm a minimalist. I'm not looking to put people on long-term drugs with side effects or addictive potentials. I'm also not looking to send people to surgery for issues that can be treated with therapy or PRP or injections. And I think if the insurance companies truly wanted to save money, that's what they would be focusing on. That's what they would be encouraging. But they're not. Either they're not that focused on that, or they're not that bright, or they're not that incentivized, or there's secondary gain, which, with the vertical integration of healthcare, who knows what's going on behind the scenes. But, I mean, I think of this. A patient comes to you, to your emergency room with lumbar radiculopathy. The ER doctors see the pain is uncontrollable. They call surgery. Maybe the surgeon comes. Maybe they can operate. Maybe they don't want to operate. Bottom line is patient sits in the hospital for a few days. How much does that cost per day for that patient to sit in the hospital versus if you have either a pain doctor incentivized or an emergency medicine doctor trained to just do an ultrasound-guided saline and dexamethasone steroid injection right there on the spot in the emergency room, and then send them to follow up with a pain doctor. Now, I've been thinking about this for years and advocating for this for years because I've seen people in my own hospital who sit there waiting for an epidural, but I'm an anesthesiologist. A lot of us are busy in the operating room. We can't run to the emergency room to do a caudal every time somebody walks in the door. Now, if the ER docs are trained or if the insurance is actually paid for it, from my understanding, they will only pay for an ultrasound-guided caudal if the patient is pregnant. And this is a very general statement. I believe that's Medicare's stance on this. However, look at this practical procedure. Now, why wouldn't Medicare pay for this? Well, I'm thinking maybe they don't want everyone and their mother doing epidurals. So that makes sense, right? We don't want that. But if you properly train a pain doctor or an ER doctor to do this, you would help a lot of people and you'd save a lot of money, as well as avoid radiation. And I do know 2 pain doctors who already got cancer. One of them attributed to the C-arm because he does lots of cases. Do I know for sure it's from that? Of course not. And then another one passed away, and I don't know if it's related, but these 2 guys are probably the 2 busiest guys I ever met in my life. One of them was doing 70 X-ray guided shots per day. So you can imagine how much radiation exposure he had with 70 X-ray guided shots per day multiple times during the week. Anyway, there's a case report that I'm going to mention here, which basically echoes what I just said about the emergency room. It's titled Ultrasound Guided Caudal Epidural Steroid Injection for Back Pain, a case report of successful emergency department management of radicular low back symptoms. And here they helped him with a dexamethasone saline injection with a little lidocaine added to it. They had 100% resolution of pain and discharge from the ER. And, you know, for all you pain doctors who are a little territorial, don't worry. That patient will probably come to your office at some point for another epidural or management. Don't be threatened by emergency medicine doctors. I mean, they're just trying to get people out of the ER safely. So it's not like you're giving away your specialty. I'd say probably be more concerned about other specialists. You know, now the surgeons are doing your epidurals and nurse practitioners and PAs. So I think that's more of something you might want to be concerned about than ER doctors. Anyway, here they mention a decrease in the length of stay in the group. That there's a reference to another study, it looks like, and they're saying that a decrease in overall care from 4,800 to the previous 33,000. So they saved over almost $30,000 by doing this. Okay, so whoever's looking at saving money for hospitals or insurance companies, I mean, maybe the hospital makes more money if the patient gets admitted, so I understand why the hospital might not be on board. But, I mean, if you're working at an insurance company, look at this and think of how much money you could save. Anyway, and of course, if you want to train your ER doctors for ultrasound, guess who I'm going to recommend? No comment. Anyway, I do private trainings as well as have this course coming up in December, which is like 3 weeks from now in New York City, February in Detroit, and another one in New York in January. And I do private courses if you have a group of people, or shadowing. You could come to my office or I come to yours for really the immersive experience. Anyway, thanks for listening. I hope you enjoyed this. I hope I made you think of things a little differently, or if you think I'm wrong and full of it, please tell me. I'm always looking to learn more and understand you guys better. So keep in touch, and good luck with whatever the hell you're doing. And hopefully this whole nonsense with Medicare will blow over, and they're not going to cut the procedures we use to help our patients and avoid unnecessary suffering, drugs, and surgery. Because if they do cut these procedures, it's going to be a disaster for not only the doctors, mainly for the patients. And on that note, support your societies, whether it's ASPN, ASRA, ASIP, your state societies, because they're fighting for us. They're advocating for us for this one. Anyway, on that note, I'm going to leave you an excerpt of a testimonial from a patient who received PRP, caudal epidural, and some PRP to the facets. If you're a patient and you're looking for a consultation, or if you're a physician and you just want someone else to treat you, and consider platelet-rich plasma or just any of the other standard stuff we do, feel free to reach out to me. My office number is 718-436-7246, 718-436-7246. Website is aabppain.com. I'm located in Brooklyn, New York.
I had the PRP completed in my back in regards to a herniated disc that I sustained back in March. Prior to coming to the clinic, I had tried all resources in my own community, including every pain management that you can think of, medication-wise, as well as chiropractic, massage, physiotherapy. I was to the point that I was so desperate that I was considering paying $30,000 to have surgery done on my back just to sustain some type of normal life. When I reached the doctors as well as the nurses here were fantastic in guiding me in to the PRP pathway for treatment. I had that completed just 2 months ago, and I have had almost complete pain relief. I'm down to taking only 1 Advil a day. When I initially came in, I was antalgic, which means that I was bent forward because I was in so much pain. My muscles were so spastic on this side that I wasn't even able to stand up straight or walk more than 100 meters without having pain. Since then, my recovery has substantially grown. I'm now no longer antalgic. My spine has completely gone straight. Prior to that, when I came in, they thought that I had scoliosis because I was so curved in my spine. I now only have slight pain, muscle pain in my back that is relieved with Tylenol. I can work a whole 12-hour day at the hospital on my feet with no problem. I'm able to provide adequate patient care, and my overall life has pretty much gone back to normal. So I just want to give a testimony in regards to the PRP. If you are thinking of doing it, I highly recommend it, as it has been very effective in my pain management journey.
So once again, I think the proof is in the pudding, and fortunately, this is a safe procedure that can be repeated. Usually it lasts at least 8 months, but many people get years out of one shot. And you don't need to necessarily do the series of 3, although some of the studies with the knee and the shoulder and the multifidus in the lower back that I found do suggest more benefit to repeat injections. However, there's still a lot of gray area when it comes to PRP, especially with the study I mentioned here, leukocyte-rich versus leukocyte-poor. We're all still trying to fine-tune our technique, and what I tell you this week might be completely different than what I tell you next week. I used to recommend avoiding lidocaine in these PRP injections. Now I advocate putting it in based on a 2022 study that I always review in my course. And it's on my YouTube lectures if you're not seeing them. Anyway, if you're interested in a consultation, 718-436-7246. Hope to hear from you. If you're a doctor and you want training, just go to nrappain.org or shoot me an email. Thanks for listening. Have a great day, and go out there and help someone.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.